Hello, everyone, to another edition of Inside Career Technical Education. My name is Jim Beloga, and I'm the president and CEO of Porter & Chester Institute and YTI Career Institute. And I'm the co-host of this podcast. My normal co-host, Ann Baldwin, isn't here with us today, but I've got a very special guest. His name is Carl Kenyon. He is the program director for our respiratory therapy program that is based out of our Altoona, Pennsylvania campus. And I'm really excited to have him here to showcase some of the equipment that he's brought. And the really great thing about this program is students who are interested in it can do it predominantly online, and they can also find a clinical experience in where they reside. And the program right now takes 8 10-week terms to complete, and the students do get an associate of specialized technology. So, Carl, welcome to the podcast.
Thank you, Jim. I'm glad to be here to show you some stuff that I brought with me on respiratory therapy.
I'm super excited, and obviously with the respiratory therapy program, who would have thought that COVID hit us 15 months ago, and respiratory therapists have sort of been vaulted to the front lines. They've always been there, but obviously with COVID being a respiratory-based virus, this has sort of brought a lot of light, I think, to students who might have some interest in and around this program. So maybe you could talk a little bit to our listeners about, what does a respiratory therapist do before we get into the equipment?
Okay. That's very interesting because previous to COVID, we were kind of a silent career. We've been there for years and years. I trained in 1984, and we were an established profession then. But with COVID, we've been brought to the forefront, and people are looking at us now and seeing what we do. And what we do is we take care of the lungs where people are breathing difficultly, and that includes little tiny babies all the way up to the elderly. One of the things that we really work on a lot is COPD or diseases from smoking, and we treat those with nebulized medication. And when people get sick or sicker, they go on a ventilator, and we manage the ventilators for those patients also.
Yeah, it's pretty interesting, and obviously with COVID, that obviously came to the forefront in terms of folks getting on ventilators, and again, it's sort of amazing to me how we go through our lives and we don't realize that there's all these professions out there that provide incredible service to our communities. So we've got some equipment on the table, but if I'm interested in becoming a respiratory therapist and enrolling in our program, is there any equipment that is sort of key or foundational for our respiratory therapy students?
Yes, the most key instrument that we have is just the basic stethoscope, and we use that to listen to the lungs and the hearts of the patient. With this, we can hear wheezing and rhonchi and bad breath sounds that indicate that the patient may need treatments or medication. And then working with the doctors, we can help prescribe their treatment course. We have, after we listen to them, then our basic line of, let's say, treatments is the nebulizer, which I have here with the face mask. But you may also know it with the mouthpiece treatment. And many people take these things at home all the time for asthma. They also take them for COPD, chronic obstructive pulmonary disease, which is caused by smoking. Health-related jobs such as construction, the dust, coal miners also come down with problems in their lungs, and they're often on these at home also. So this is our basic tool along with our stethoscope.
And so students who are attending our program, obviously we have these in our industry modeled lab back in Altoona, but for students who might be attending our program from other places outside of sort of the greater Altoona area, which we now have students that are there, this equipment would be located in the hospital or the clinical environment that they would be attending. So they this isn't part of any sort of toolkit or anything like that they get, but it would be a key piece of equipment at their clinical experience.
That's correct. So they get, as far as their ownership, we provide them with a stethoscope,
Yep.
and we provide them with two sets of scrubs, wine-colored, with embroidering YTI Respiratory Therapy on it. Then we do their academic education online, and they can take that pretty much at different locations throughout the whole country. Then when they go to clinical is where they get their hands-on experience with all these different equipments. And they do that at the hospital sites that we have agreements with, where they are provided with a clinical instructor that takes them around the hospital, introduces them to very basic care. Hello, this is the first patients I've ever seen. We're going to do a breathing treatment on you. We're going to listen to your lungs. And the professional that's with them shows them and walks the student through.
Sure.
Just like any hands-on learning that you do. That's actually the way that we would do it in the residential course too.
Sure.
We do all our academic learning in the classroom in the old days, pre-COVID, and then we go to the hospital to learn how to work this equipment. So that's exactly what we're doing now. Except we're doing it in multiple locations around the country.
Sure, yeah, exactly. So we have students who are now enrolled in our program who are from states outside of Pennsylvania. So in really areas outside of Altoona, Pennsylvania, because when we were a pre-COVID residential program, now we've got this, I'll call it a blended online program where about 75% of the curriculum is lecture online. And then the remaining, I think 26% is done in a clinical environment where they reside. So it's really, I think it's an unbelievable program in terms of our ability to reach the country and provide this education. So why don't you? It looks like you've got stuff that you want to show, really sort of share here with us. I see there's some saline or something over there, and
so what I have here is just a nebulizer with some saline in it, which is pretty much normal saline or salt water, just for demonstration. But if a patient comes in and they have trouble breathing, we usually would listen with our stethoscopes to try to see if we hear wheezes. And then we would consult with the doctor, and he would prescribe a bronchodilator, which will open up the airways. And this is our basic nebulizer. Now this is our compressor, and we'll turn this on with a little bit of noise.
There you go.
But that creates this mist. So the patient's awake, and we'd give this to the patient, and he'd be breathing in this, and this would hopefully open up his lungs, and he'd get better. And the ER physician would say, okay, you're going to get these treatments at home 3 times a day for the next 3 weeks. Come back and see me.
Right.
In the course of another patient, he might get this treatment, but he doesn't get better, and he becomes a little bit sleepy, so he can't hold that in the mouth. We'll put a mask on him, and then he would wear it. Gonna mess my hair up. Yeah. He would wear this like this, turn this on, and he can breathe that in while he's asleep. Now that same patient may improve or he may get worse, and we're going down the line of a patient who's getting worse and worse. So after this, he may need more intensive care. He may have secretions building up in his throat, and we would use a suction to stick this into his mouth and his upper airway to suck out secretions. If we have a clear airway and the patient continues to deteriorate, we also draw blood from the patient to measure his pH, his CO2, and his oxygen level in a blood gas. And if it's bad enough, he's not breathing well enough, he's not exchanging oxygen, then our last course is intubation, where we put this right here is an endotracheal tube with a stylet that keeps it lined up. And we feed this in through the upper airway down into the trachea and inflate this balloon. And then with our bag, we can breathe directly into his lungs and take over his whole breathing. He can be sedated. We can apply 100% oxygen. We can apply various pressures, driving pressures to get that oxygen across the membrane into the bloodstream. We can increase the positive and expiratory pressure, which is the amount of pressure that's left in your lungs when you're done breathing. So if we increase that, our normal's about 3 without any tube. You have 3 about right now, Jim.
Sure.
If we put a tube in you, we can increase that up to 20 without any problems, and then that just pushes this oxygen gas into your lungs more efficiently. And it also helps to get the CO2 back out so that we can improve the patient's status. And hopefully, while we take time to do that, which might take a week or 2 weeks, the underlying cause of what's going wrong can be corrected.
Wow. I feel like I've just been in the respiratory therapy program myself. Hopefully all of our viewers have enjoyed that very, very detailed explanation. My gosh, what a lot of information. So if you are interested and do want more information, I would encourage everybody to go to YTI.edu. And I want to thank Carl for joining me today. I found this personally to be quite informational and educational. And again, I want to thank all of our viewers for attending this edition of Inside Career Technical Education.